Hello, everyone. My name is Olivia Jackamarts. I'm a mental health trainer for ViaQuest Psychiatric and Behavioral Solutions. And today we are going to be going through reasons and supportive actions for problematic behaviors. So first, we need to know what we're trying to learn today. So our objectives here, we want to learn some basics about specific mental health disorders. We want to know what the reasons are for problematic behaviors. We want to learn why symptoms may present as problematic behaviors. And we're going to learn about those de-escalation techniques and supportive actions for problematic behaviors. So during this training, we are going to touch on just a few mental health disorders, as well as what is trauma. So depression, bipolar disorder, anxiety, as well as we will get into schizophrenia versus schizoaffective disorder. Along with this discussion, we will incorporate ways we can support individuals who have those problematic behaviors. So first, we will watch a quick video here to give us a broader perspective of what is mental health.
What is mental health? This two-word term has a hold over so many facets of our lives, but with so many people talking about it in so many different contexts, it can be easy to forget what it means. So with that, mental health, put simply, refers to the state of a person's psychological and emotional well-being. Think of it this way. We all know the word health is used to describe someone's physical condition, but it doesn't say anything specific about how an individual is doing. That's what mental health is, only it exclusively refers to someone's mind. Mental health is made up of a few things: a person's ability to handle their emotions, their thoughts and feelings, their connection to others, and how they manage life's highs and lows. A lot of people seem to confuse mental health with mental illness, but they are definitely not the same. Mental illnesses are diagnosable mental conditions that can hinder a person's day-to-day functioning. Think depression, anxiety, mood disorders, things like that. It's like diabetes, but for your brain. You may have these conditions for life, but they can be managed. Mental health, on the other hand, is a neutral term. Again, like the word health, but for your mind. Not everyone will experience a mental illness over their lifetime, but everyone has mental health. Now, mental health doesn't mean being happy 100% of the time. Life throws all sorts of challenges at it, be it school or work or family stuff or just everyday ups and downs. It's about how someone deals with these challenges, which means someone can live with a mental illness their whole life and still have great mental health, while someone else can have technically nothing wrong with them but have bad mental health. Just like our grounding rod of physical health, mental health is on a spectrum. On one end of the spectrum, you have people who live their entire lives with no issues. At the other end, you have people who almost constantly live with serious problems. And in between those extremes, you have people who can go through moments in their life where their health is either good or bad, with good or bad also being on a spectrum. A bunch of factors can work together to influence where your mental health falls on that spectrum. These factors can be individual, like genetics, upbringing, personality, or substance abuse, or they can be external, like the state of the world or your exposure to poverty, inequality, and violence. So at this point, we talked about mental health and physical health like they're two similar but separate things. But actually, they're very much connected. As I'm sure many of you have experienced, your physical health can affect your mental health, but your mental health can also affect your physical health. Like a snake eating its own tail. People with mental health issues can experience insomnia, restlessness, difficulty concentrating, and poor mental health has been linked to chronic illnesses and diseases. For example, depression has been shown to increase your risk of heart disease, stroke, and digestive issues. On the flip side though, physical health issues can lead to poor mental health since dealing with medical challenges can be draining. That's why it's important not to neglect your mental well-being. Think of it as a preventative measure so you don't get even more hurt when you're sick. So if you're feeling run down, burnt out, or a little wibbly wobbly, let this video be your sign to take a nap, watch a movie, reach out to your support systems, or do something nice for your brain. Your whole you will thank you. And now you know what mental health is, how it works, and why it's important to prioritize. Thanks for watching this episode of TVO's What is Explainers. If you have another topic you would like me to explain.
So it is important to understand that many of the individuals served are diagnosed with various mental health disorders. Many times, behaviors that these individuals are displaying are the result of symptoms of those disorders. It's important to become aware of the symptoms of those disorders so that way you can just recognize them when they occur. Noticing these signs and symptoms before your client reaches their breaking point can be the difference between escalation or de-escalation. So having an awareness of these symptoms helps successful positive interactions, because this is increasing knowledge and awareness, and we are able to separate the person from their mental health diagnosis. So when someone has a mental health diagnosis, their symptoms can present as various different responses. First, we're going to look at those behavioral responses. So what does the behavioral response look like? Well, that just depends, because responses can take different forms for different people and circumstances. This is because mental health is a very subjective experience, meaning that responses are going to be unique to the individuals. It may also depend on if there has been any trauma experienced by the individual. So some of these responses are going to be familiar to you. You may have seen these or similar reactions when working with a client, or you personally have experienced your own trauma response. So some behavioral responses are those reactions that we can see and observe happening. So it could be that they're blowing up when corrected, a complete overreaction to it. They could go immediately into fighting mode when someone is criticizing or even just teasing them, not being intentionally harmful, but just playing. Or maybe your client is being resistant to transitions or changes, not being cooperative when those occur, refusing, or just making it difficult for themselves. Someone could be very protective of their personal space, so not wanting or trusting others to be too close, and they may become aggressive if they feel threatened by someone being in their space, being too near. Engaging in reckless or self-destructive behavior can be dangerous. Are they taking more risks than normal? And frequently seeking attention, any kind of attention, good or bad, attention is attention. And reverting to younger behaviors, things that you haven't seen for quite some time, or even things from their past before you are working with this individual. And then there are those psychological responses. So these can be a little bit more difficult to recognize, and they may not be as obvious as those behavioral responses. Psychological responses include being confused about what is safe and what is dangerous, which can go hand in hand and can contribute to exhibiting more reckless or self-destructive behaviors. There's trouble focusing or concentrating. Maybe you find that you're having to repeat things to your client before getting a response, or maybe the client is just asking the same questions over and over. As well as there's difficulty imagining the future. So they aren't making future plans because they just can't imagine it happening. And then that leaves us with those emotional or physical responses. So these are also tangible actions that can be observable. So first are those nightmares or sleep problems, especially if these are not issues that have been had previously. Maybe the nightmares are becoming more pronounced. Maybe sensitivity to noise or being touched. Is your client shying away from being around others or participating in activities they would normally enjoy? They don't want to be around people for fear of being touched or someone bumping into them. Noisy environments just tend to be difficult for our clients. Could be fear of being separated from family or friends and not being able to trust others. You notice that they're feeling very sad, angry, afraid, or they seem to be experiencing emotional swings. One minute they're smiling and happy, and then just a short time later, they're crying or angry. And then there are those unexplained medical problems, feeling sick, unexplained symptoms when they're normally healthy. So someone who has a mental health diagnosis can have different responses depending on that diagnosis and the symptoms that go with it. Many times, a person's response to any given situation or event will be a direct result of their mental health diagnosis. So now moving into the mental health diagnoses, starting with depression. So what is the difference between depression and an episode of major depressive disorder? Well, to start, what exactly is depression? Well, it's that everyday feeling of being blue, that sadness, grief, or being depressed for a short period of time. It's really not uncommon for people to cope with these feelings without any significant impact to their life. It's not hindering their day or causing disruption of daily living, and it is manageable. But what if it's more than that? What if it goes beyond that short-term depressed mood? So when those feelings impact now everyday living, is when it is becoming an episode of major depressive disorder. So those depressive symptoms occur and last for up to 2 weeks, either daily or almost every day, and all or almost all the time. When those symptoms are affecting all aspects of your life, your emotions, thinking, your behavior, and physical well being, then it is absolutely impacting your ability to live your life. Your work is affected, as well as the ability to have satisfying relationships. So, these are some depression symptoms that can be experienced. Bearing in mind, these are also observable clues for you to be able to intervene or offer assistance before your client's escalation point is reached. First, sleep disturbances. Have you noticed your client sleeping all day, staying up through the night, or maybe the opposite? Really, anything different than what is baseline or normal for them. And then changes in the appetite or body weight. So, some people choose to use food as a coping skill, causing their weight to increase. So, using this kind of like a self medication. Then again, maybe your client doesn't have an appetite at all and they're losing or have lost a significant amount of weight. There could be bad mood. So your normally cheerful client has become irritable, snapping at those around them, or they may be sad, tearful, or down. There could be a loss of interest in activities, personal appearance, and motivation. So they aren't enjoying activities that they normally would. They show no interest in doing anything. They aren't showing any interest in their own appearance, not showering or bathing regularly, not brushing their teeth, their hair, or even bothering to put on clean clothes. They just seem not to care. A common misconception is that the client may just appear to be lazy. They just don't want to, when in fact, these are depression symptoms that they are experiencing. Then fatigue. So your client is complaining of being exhausted and tired. This is not just the regular tired either. They seemingly have no energy. And then difficulty concentrating. So they may lack concentration or have difficulty focusing on the task at hand. And low self-esteem. So clients may have low self-esteem, low to no self-confidence at all. They don't feel like they're good at anything or have anything positive to offer. And feeling hopeless and or helpless. So during discussions, you're hearing your client express feelings of hopelessness or helplessness, that they have nothing to look forward to, not seeing anything positive in their present or future. Some other symptoms just to be aware of include suicidal thoughts or preoccupations with death. So your client or patient may be expressing that they're having thoughts of suicide or that they have become preoccupied with death, talking about going to sleep and not waking up. There could be withdrawal from others. So a person suffering from depression may become withdrawn, isolating themselves away from people and places they would normally seek out or interact with. And then a neglect of responsibilities. Same kind of aspect with the loss of interest in just activities or motivation. Your client may be neglecting basic responsibilities. Their living area or home is a mess with dishes piled up and clutter everywhere. Their living space is just a mess and they have no ambition or desire to take care of or clean it. And moving into bipolar disorder. So, bipolar is characterized by periods of depression and mania that cycles. So, someone is experiencing symptoms of that major depressive disorder, which we have just covered, and then they will have a period of time when they are experiencing those mania symptoms. So, mania is a very intense group of symptoms and usually lasts at least a week, but can last longer. So bipolar 1 mania can make some people think that they're almost invincible, which can cause them to engage in risky behaviors, make snap decisions, and overindulge. Some people's mania episodes can become dangerous and life-threatening, requiring inpatient care and hospitalization. They can also get into injury-causing accidents. Symptoms of mania include increased energy and being overactive. So your client goes on a cleaning spree. They're scrubbing walls, doing laundry, organizing closets, cabinets. They're really just going 90 miles an hour and getting a large amount of work done in a very short period of time. Maybe easily distracted. So think of some of those funny jokes, right? Oh, look, a squirrel. Ooh, shiny object. But without that funny. Your client has difficulty staying focused on the task at hand without becoming distracted from it. And they may need less sleep than usual, so they feel well rested after only a few hours, whereas normally one would be tired, maybe cranky, not feeling rested at all. And that elation or severe irritability. Have you noticed your client being in an exceptionally good mood and not necessarily having a reason for it? Or are they just irritated by everything, snapping at those around them, being very, very short tempered with people? There could be rapid thinking in speech, including racing thoughts and talking more than usual. So, talking faster than they normally would, trying to keep up with the thoughts running through their head, and excessive involvement in potentially high risk activities. So, those excessive involvement in activities that have a high potential for painful consequences, doing things that can have those painful consequences, spending money that they can't afford to spend, having unsafe sex, driving fast, or turning to drugs and alcohol. There's a lack of insight. So, then not being able to see how these behaviors may have the potential to be destructive or just not care. There could be an inflated self esteem. So, feeling that they are bigger, better, smarter, and faster than the next guy. Or maybe they can one up everyone. Whatever you can do, they can do or have already done so much better. Some symptoms of bipolar 1 mania can also include breaks in reality, things like hallucinations or delusions. So, just a quick note here regarding bipolar. We have been referring to bipolar 1 and this big mania. There is also bipolar 2 disorder, which includes depression and hypomania. Hypomania being literally below mania. So, during these hypomanic episodes, people can still make these snap decisions, take risks, but they're not usually as dangerous or extreme as bipolar 1 manic episodes. And people with bipolar 2 also do not experience these psychotic symptoms that may arise. So I just bring up these differences as it is more common for individuals to be diagnosed with a bipolar 2 disorder rather than a bipolar 1 disorder. And we do have another video here.
So mania
it's going to be regarding the mania aspect from someone who has experienced mania.
what people would know as the happy half of bipolar disorder, I suppose. It's when you experience mania, it can creep up slowly, you can feel it coming, but there's nothing you can do. There's this misconception that being manic is fun. It certainly can feel that way at the time, but it's exhausting. It feels like something is stuck inside you, trying to get out. You just keep moving around, trying to release it, but it only makes it worse. And at first it's just little things you notice, like not needing to sleep, you're feeling restless, you're talking really fast, you're talking a lot. You'll want to go out and be social, be the life of the party, start new things, buy new things, and then get over them just as fast. You're fun, you're creative, you have all these ideas, and you just want to show the world what you can do. And it feels like the best high in the world, and you could do anything. And you kind of wonder why anyone would think that there's something wrong with you. You can embrace mania as a gift, but you can't control it. So you always have to be careful about crossing the line between being this creative genius or some kind of hazard to society. And you'll do anything to avoid crashing into depression. Suddenly you can't take your foot off the accelerator, so everyone and everything is moving too slow, so you keep going faster. You're too loud, you're too intense, and you scare everyone away from you. Your thoughts are racing and everything seems so far away from you and what you feel inside your mind. And so you might try and ground yourself, take a breath, focus on something slow, something calming. And then once you've found a series of constructive activities to drain your energy into, you start to feel like maybe, you can have some kind of control over this illness.
So next that we're going to get into is anxiety. Anxiety is something that almost every one of us has experienced to some degree in their life. So it's really normal to experience worries and stress, and some anxiety and stress can even keep us safe and motivated. So anxiety disorders are another thing altogether. So it has been found that an estimated 31.1% of US adults will experience any anxiety disorder at some time in their lives. So almost a third of the US adult population will experience any anxiety disorder. So with anxiety disorders, the anxiety is just so much worse than the everyday stress one would experience. It is more severe, lasts much longer, interferes with your daily life. Your work is impacted by being constantly late or calling off, not meeting performance expectations, or completing tasks for work. It could be that someone is so worried about the work that they produced being perfect that they just don't produce any. And those regularly daily activities, so cleaning the house, doing dishes or laundry, these things aren't getting done. If someone is battling an anxiety disorder, personal relationships also end up getting negatively impacted. Some of the more common symptoms of anxiety include faster heartbeat or breathing. So, by nature of the anxiety and stress hormones running through the body, individuals may be experiencing both a faster resting heartbeat and breathing, as well as can escalate quicker. There could be an overwhelming sense of fear or worry. So, there is that feeling of unease or dread. It's really constantly on their mind. They're fearing the worst, or maybe experiencing the fear and worry for a worst case scenario of a situation. And then those physical or somatic symptoms, such as sweating more, even experiencing erratic bowel movements or more urination, things like muscle aches and pains that are not explained due to physical activity or illness, as well as headaches. So they could be complaining of them more frequently, or the client doesn't have a history of headaches and they are due to any other diagnosis or injury, excuse me. And then the irritability. So is your client in a bad mood or just more easily angered than usual? Difficulty focusing or concentrating. They may not be able to complete tasks or get distracted during conversations. There's nervousness or restlessness. Maybe they appear fidgety, antsy, not being able to sit still, possibly pacing or twiddling fingers and tapping their feet, and just startling easily, being jumpy. Other symptoms include insomnia, so they aren't sleeping despite trying, as well as just weakness and fatigue, so no energy or stamina, unable to complete simple physical tasks, complaints of being tired, and that muscle weakness. And next up, we're going to get into psychotic disorders. So this disorder is characterized by a condition in which a person has lost some contact with reality. So someone with a psychotic disorder could be experiencing severe disturbances in thinking, emotion, and behavior, along with this loss of contact. And something of note here is that psychosis generally occurs in episodes. So it's not a constant condition that someone is experiencing. First, schizophrenia. So schizophrenia is a serious mental illness that affects how a person thinks, feels, and behaves. People with schizophrenia may seem like they have lost touch with reality, which can be distressing for them and for their family and friends. The symptoms of schizophrenia can make it difficult to participate in those usual everyday activities, but effective treatments are available. Schizophrenia symptoms are generally categorized as positive, negative, and cognitive. So positive symptoms are going to be those changes in thoughts and feelings that are added on to a person's experience. That may be that they're having hallucinations, delusions, or they may be hearing voices. And then there's those negative symptoms. So these are when things are taken away or reduced. They have reduced motivation, there's reduced intensity of emotions. The person may experience unusual or extremely slowed movements. And then those cognitive symptoms. So these are the problems with how the brain learns, stores, and uses information. It could be that it's looking like they're having difficulty focusing or concentrating. The person is having short and long-term memory problems, and or they have problems with executive functioning. The two main positive symptoms we see in our clients who are diagnosed with psychotic disorders are hallucinations and delusions. It is very important to know the difference, and we will be getting into that in just a moment. So first, if you are someone who may be triggered, please be aware that we are going to listen to what it can be like for someone who's experiencing hallucinations. So this is going to be an auditory recording of what an auditory hallucination may be like.
You are the one. I came for you. I came for you because you are the one. It's you. You are the one I came for. You
Stop
are the one. It's you. It's you I came for. It's you.
Look at their
and you
eyes.
have the way.
Look at them.
I
Their
came
eyes are
for
full
you.
of disgust.
You have the way.
You smell. You are disgusting.
We know you.
They're looking at you and seeing you, and they see everything you do, and you are disgusting. Disgusting. Yes. Hey, stop it. Stop it now. Don't touch that. Stink. Stinky. Stinky, stinky, stinky. Dirt. Shirt. Alert. Jerk. Wipe the smirk off your face. You think this is funny, don't you, huh? You think this is some kind of joke? Well, it's not a joke. Not a joke. What are we going to do with you? It's funny. It's not funny. It's sick. You're sick.
So that was a lot, right? It's really important to know for our clients who may be experiencing hallucinations or delusions that they are really experiencing that. That is actually what their reality is. So it is really important just to make sure to understand, give people more time to process, and just know, right? Know what they may be experiencing. So looking at our hallucinations and delusions here. So the hallucinations, this is the experience of seeing, hearing, tasting, smelling, or being touched by something that is not present. The hallucinations have to do with your senses. And then the delusions. So delusions here are going to be different. These are the impairments in thought patterns that are not based in reality. So some examples here. So believing that you are a celebrity, actor, or person of importance. This is a delusion. But thinking the weatherman is talking to you, that is also a delusion. Spiders are crawling on the wall. That's going to be a hallucination. Believing secret agents are following or listening to you, that is a delusion. And feeling ants run along your body, that is a hallucination. So anything that has to do with the senses, actually sensing something, that is going to be hallucinations. Whereas the delusions, that is going to be that thinking and thought patterns. So we are now going to move into schizoaffective disorder. So schizoaffective disorder can cause dramatic changes in thoughts, moods, and behaviors, and can often last throughout a person's lifetime. People with schizoaffective disorder have the same symptoms as someone diagnosed with schizophrenia, like hallucinations and or delusions, in addition to having symptoms of another disorder, either bipolar disorder or depression. Schizoaffective disorder can cause those dramatic changes in thoughts, mood, and behavior, and there is no cure for schizoaffective disorder, but treatment can absolutely help manage symptoms and improve overall quality of life. So looking at the difference between schizophrenia and schizoaffective disorder.
Here at BrightQuest, we often see a lot of clients that have been diagnosed with schizophrenia or schizoaffective disorder, and those two often can be confused. With individuals that are diagnosed with schizophrenia, they often have symptoms such as hallucinations, delusions, negative symptoms, things like that. Those that are diagnosed with schizoaffective disorder have those components paired with a serious mood component as well. So they might have periods where they are very, very low in their mood. They might have periods where they're very high, but it's combined with the symptoms of delusions, paranoia, negative symptoms. What that means when I say positive symptoms is the addition of things. So that means they're experiencing hallucinations, they're experiencing delusions, so they're having extra things happening to them. The negative symptoms is not something that you would typically think of things I don't want. Negative symptoms actually means the subtraction of things. So that might mean that they do not have the ability to show affect. They do not have the ability to have social interaction as well as somebody that does not have those symptoms would maybe present with.
So next we will get into trauma. So individual trauma is the result of an event, a series of events, or a set of circumstances that is experienced by an individual as physically harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and their mental, physical, social, emotional, and spiritual well-being. It really is just a result of anything that disrupts one's sense of safety. So trauma doesn't look like any one event or circumstance. Trauma can and will look different from everyone. That makes getting to know your client and their history an important first step in order for you to be aware of any triggers that are a direct result of trauma in their past or possibly still impact them. Think about trauma can impact your client and their mental health diagnosis. It can be triggering for them, or it could cause their symptoms to become more severe. Maybe they become irritable or are startled easily, causing them to overreact or lash out. Not because that they are just grumpy, but because they have experienced trauma, and that is part of the impact it is having on them. And then we have our ACEs. So ACEs are adverse childhood experiences. These are potentially traumatic events that occur in childhood. ACEs can include violence, abuse, and growing up in a family with mental health or substance use problems. Toxic stress from ACEs can change brain development and affect how the body responds to stress. For individuals who have an intellectual or developmental disorder, they are at a higher likelihood of experiencing early trauma, and those individuals who have early trauma are more likely to develop an intellectual or developmental disorder. And data shows that there is a striking association between trauma and illness. The seminal ACE study provides estimates of odds ratios for having conditions in adulthood if a person has experienced these adverse childhood experiences, these ACEs. So ACEs are strongly correlated with adult disease. People who have experienced 4 or more categories of ACEs have twice the rate of lung and liver disease, 3 times the rate of depression, approximately 3 times the rate of alcoholism, 11 times the rate of intravenous drug use, and 14 times the rate of attempted suicide. And trauma-related disorders. So trauma-related disorders are conditions that can be directly linked to traumatic experiences. Some related trauma disorders are post-traumatic stress disorder or PTSD. So this is probably the most well-known of the traumatic-related disorders. PTSD is a mental health condition that can develop after a traumatic event and continues well past what would be considered a normal reaction. Some symptoms include being easily started, can't stop thinking about the traumatic event, panic attacks, unable to concentrate or focus, feeling overwhelming guilt or shame, and symptoms can be experienced from the time of the traumatic event until months or years later. And then acute stress disorder. This typically occurs within 1 month of a traumatic event and will exhibit those similar symptoms of PTSD, but not as long lasting. This disorder is considered a short-term or temporary disorder. It is possible for one to be diagnosed with acute stress disorder and go on to develop PTSD. Other symptoms can include dissociative symptoms, re-experiencing the traumatic event, avoidance, anxiety or increased arousal, distress, or disrupting the important aspects of one's life. And then adjustment disorders. So this is a group of conditions that can occur when someone has difficulty coping after a stressful or traumatic event. Some of the common symptoms can include impulsive actions, feelings of sadness, hopelessness, crying, withdrawal, unable to concentrate, just to name a few. There are 6 types of adjustment disorders. So adjustment disorder with depressed mood, with anxiety, with depressed and anxiety, adjustment disorder with disturbance of conduct, adjustment disorder with mixed disturbance of emotions and conduct, and adjustment disorder unspecified. So while these are just a few trauma-related disorders, it is not all of them. And when looking at the difference of acute stress disorder and post-traumatic stress disorder, both are stress disorders resulting from direct or indirect exposure to one or more traumatic events. Traumatic events can include continuous domestic abuse, bullying, chronic medical illness with invasive medical procedures, homelessness, neglect, starvation or deprivation, ongoing war or combat, and witnessing constant abuse of a partner or family member. This is not an exhaustive list, and many more things could be considered a traumatic event. So ASD, the acute stress disorder, this is diagnosed when someone has had a direct or indirect exposure to a traumatic event and has experienced at least 9 qualifying symptoms. These symptoms must continue for at least 3 days, but resolve by the end of 1 month. Those who meet full acute stress disorder criteria do have higher chances to develop chronic PTSD if they do not get the right treatment for their symptoms. And then chronic PTSD is a longer lasting form of the disorder that occurs when symptoms last for more than 3 months. So clients with chronic PTSD may have more severe and persistent symptoms, including difficulty with relationships, work, and daily activities. Chronic trauma is repeated and prolonged, such as domestic violence or abuse, and the word chronic refers to something that keeps recurring or has persisted over a long period. Chronic PTSD is an ongoing condition after a shocking or distressing event. While it's not unusual to experience emotions like shock, fear, or increased anxiety after an upsetting event, these feelings usually lessen as time goes on. Chronic PTSD causes people to experience intense feelings over that long period of time. The symptoms for both look the same and can include recurring memories of the distressing event, nightmares or flashbacks related to the event, a loss of memories or disassociation related to the event, sleep disturbances, difficulty focusing, trying to avoid any kind of reminders of the event, as well as any kind of additional symptoms, such as experiencing intense stress, hypervigilance, angry outbursts or irritability, and any kind of elevated response to stimuli, such as sudden movements or loud noises. And then our adjustment disorders. So an adjustment disorder is also diagnosed when the symptom pattern of PTSD occurs in response to a stressor that does not meet full PTSD criteria. So it could be a spouse leaving, it could be being fired or moving. It is the development of emotional or behavioral symptoms as a response to an identifiable stressor, and those symptoms are occurring within 3 months at the start of the stressor. The presence of emotional or behavioral symptoms in response to this identifiable stressor is the essential feature of an adjustment disorder. In a hospital psychiatric consultation setting, It's often the most common diagnosis, frequently reaching 50%. By definition, the symptoms in an adjustment disorder begin within 3 months of a stressor and last no longer than 6 months after the stressor or its consequences have ended. Once the stressor or its consequences have stopped, the symptoms should not persist for more than an additional 6 months. If they do, it is no longer adjustment disorder. So recognizing the early signs of someone in distress and taking the necessary steps to help redirect them using coping strategies to assist one to calm down and avoid escalation. And understanding the cycle of escalation, also called the anger arousal cycle, allows us to recognize behavior patterns and help us avoid those triggers that affect our patients. Let's go through those stages and discuss what that looks like. So there is the trigger phase, escalation phase, crisis phase, recovery phase, and post-crisis or depression phase. So we're going to break these down and get into some more details about each of these. So the trigger phase is where it all begins. This can also be called the activating event or the antecedent. So this is when an event causes us to feel dysregulated at some level and our physiological system is preparing to respond. Something has happened that the client is now feeling overwhelmed, anxiety, they're feeling sadness or distress. Triggers can look differently for everyone. So it could be a sudden loud noise like a car backfiring or a balloon popping, or it could be times of transition or changes in the routine or schedule. So there is not a standard or limit for what can be triggering for a person. Is there a way for us to intervene at this point to prevent any kind of escalation? Yes, absolutely. So if we can safely do so, we can move or remove the trigger itself, or we can move the person to a different area. It is possible with early intervention to successfully stop the cycle right here. Moving into the escalation phase. So the escalation phase is when we will see or feel those physical signs when the body is preparing for what it perceives as a crisis. Physiological signs such as increased heart rate, rapid breathing, it could be tensing of muscles, becoming more vocal, making threats towards others or harm to self. At this point, we absolutely should be remaining calm, use positive language, and give space for the safety of all involved. Offer to help however you can. This is the last point where we can de-escalate before full dysregulation happens. And then there is the crisis phase. Crisis is when the survival instinct kicks in. It is now fight or flight time. The body is ready to act, but our judgment is significantly impaired at this point. Irrational decisions are being made with logic and reason out the window. For providers, remaining calm, using short, simple words and sentences, offer empathy and using active listening to fully grasp what the problem is what you'll want to do. Help them to find a way out by giving choices to guide them. Can we go talk in your room? Or let's take a few minutes and take some deep breaths. It's important to remember that the person is not thinking clearly, so it's up to us to ensure that we are. At this point, make sure to anticipate some of the body sensations of this stress response. Our clients are often experiencing tunnel vision or tunnel hearing. They have a diminished cognition and working memory. They have that shaky feeling, the vasoconstriction happening, as well as time distortion. 2 minutes can feel like 2 hours, or 2 hours can feel like 2 minutes. The goal is always to respond to these bodily sensations and not react. Just make sure to understand that there is a strong relationship between beliefs and emotions, and people typically have more control over the associated beliefs rather than the emotions themselves. We'll move into the recovery phase after the crisis has occurred. So recovery will occur after all the excitement of the previous 3 phases. the body will slowly begin to recover from the extreme stress and expenditure of emotion and energy it just experienced. Adrenaline will gradually return to normal and rational thinking returns. While it may seem to happen just as quickly as it started, be mindful that it does take some time to truly and completely calm down. Give them some space and some quiet time to themselves to fully recover. Hold off on any problem solving immediately after the crisis. Problem solving should be done when the person is in a better state of mind. Lastly, the post-crisis depression phase. So the body actually enters a short period when the heart rate slips below normal to allow the body to regain its balance. The person will oftentimes also regain awareness and energy. During this phase, the person that has been aggressive and violent might feel tired, unhappy, guilty, or even ashamed about the incident and their behavior. What if they had hurt someone or caused damage during the crisis? It's important to be forgiving, be kind, supportive, and remain positive. They need that support and the knowledge that they will still move forward, that you are still there. This is the ABC model of a basic CBT technique. So it is assuming that one's belief about an event affects how one reacts to the event. The ABC model was developed by Dr. Albert Ellis, a psychologist and researcher. The name literally refers to the components of the model. So A is the antecedent or the activating event. That is the trigger. B is the beliefs about the event. It involves both obvious and underlying thoughts about situations, yourself, and others. Then there is C, the consequences, which includes your behavioral or emotional responses. It's assumed that B is what is actually linking A and C. And additionally, B is considered to be the most important component. The activating events can be the same for two different people, but if their beliefs are different, the consequences will also be different. So what exactly do we mean when we're talking about behavior modification? Well, we mean exactly that. So working with our client to modify any negative behaviors into positive, productive ones. By understanding what makes up the entire episode from start to finish, we can understand where and when we can intervene to help prevent those behaviors we would like to see less of and replace them with more appropriate, safe behaviors. Well, what set the behavior in motion? That's going to be the antecedent or the activating event that occurred that triggered the individual. Maybe it was a loud noise or someone arguing, but there will be a specific something that set the ball rolling. What is then the response to the antecedent? That will be the actual behavior, what the person actually did. Did they cover their ears and yell when they heard the loud noise? Or maybe when they heard or saw arguing, they ran away, hid under a table. Consequences are what come after the behavior, after the response. So how can we relay to someone which behavior we would like to increase and which we would like to decrease? This is where positive or negative reinforcement comes into play. Positive reinforcement, we add a stimulus following a behavior that results in the behavior being increased or maintained. Think of it as rewarding good behavior. A child is rewarded by being allowed to play on their tablet once they completed their homework. The positive behavior will be repeated. And negative reinforcement. Negative reinforcement is different in that we're removing an unpleasant stimulus following a behavior that will then result in an increase or maintenance of that behavior. In this instance, the child will complete their homework to avoid having the tablet taken away. Reinforcement is always going to be an increase of a specific behavior. Reinforcement is increasing or maintaining a behavior. If we want to decrease a behavior, We are instead utilizing punishment. And negative reinforcement and punishment are not the same. Again, negative reinforcement, we still want the behavior to increase, and a punishment, we want the behavior to decrease. So getting into that antecedent control. So that's the first and foremost thing. It always starts with a trigger. If there's no trigger, there's no behavior. So when observed, the antecedent is our best opportunity to intervene and stop the potential of escalation. As soon as it is observed, act. But how do we know that someone is being triggered? How will we know what that antecedent is? Well, that's likely going to depend on the person, the environment, what is going on in that moment, and there could be a number of factors. You will learn to rely on your powers of observation and on what you know about the person. What do you see in their environment? Is it noisy, cluttered? Is it a rainy, dreary day? Or is it freezing in the room? Is someone in their space touching them or their things? Did their schedule get thrown off? Is the TV or music too loud? Maybe your patient has been struggling ever since his last visit with his family, or they just got a new diagnosis, or either their physical or mental health is deteriorating. They could be experiencing symptoms from past trauma. For the patient, this is going to be patient specific. So it's clearly going to take a little more effort on the clinician's part to find out what's going on here. These are the things that may not be observable or seen. Talk to the person and help them figure out what's going on, and then hopefully we will avoid any more escalation on their part by getting to the root of the problem. And then interactions with others can be triggering for someone. If they've had a disagreement or argument with a loved one or close friend, maybe they're being teased or bullied at school or work, being ignored by someone they care about, have had confrontations that make them upset. Maybe you have not interacted with the client in the most professional or respectful way. Make sure to offer support and encouragement while engaging with that person to try and figure out what's going on and how you can help them. One of the most important things we can do as providers is get to know the person. Pick up on those patient-specific triggers and then avoid them. Again, if there is no trigger, then there's no behavior. Make sure to observe. Listen to the person, not just with ears, but also the eyes. Pay attention to body language and actively listen and process what the person is saying. Listen to others who may know the person well, maybe guardians, family, friends, or other staff members. And always review the individual's documents and always document yourself. So, reducing behavioral escalation. We should be following these principles daily anyway when we are working with our patients and clients. Our everyday interactions are a great way to model positive behaviors we want the client to exhibit. Focusing on the person, what is going on with them in that moment of possible escalation can then decrease any escalation. And all people, not just those in treatment, need to feel heard or cared for before they become re-regulated. Let them tell you what's happening and then repeat it back to them, saying what you are perceiving the issue to be. And you may even ask them, is that correct? Am I understanding right? If not, that's perfectly okay. It is okay to be corrected. Just get it clarified by the person you're supporting. And then if so, keep moving on. Offer statements of validation and empathy. Let them know that you heard and understand. I understand that you're feeling frustrated with this right now. I see that you're feeling this. I'm sorry that this is happening to you. And then follow up with offering or showing that you care and are there to help them. Letting a person know that someone genuinely cares about what they're going through can mean a lot when someone is struggling. So bring in these statements of assistance. How can I help you? What can we do to make things better? What can we do that will make you feel safer? Asking these kinds of questions can also give voice in being able to decide for themselves exactly what will help. Figure out exactly what the client is getting out of the behavior. This is a huge step in de-escalating that person. Knowing what need is being met allows you to explore options that can potentially meet the same need, but in a more appropriate manner. It could be meeting a physical need. So someone is hungry but unable to get their own food. Or maybe they aren't feeling well and aren't able to effectively communicate that. What if it's an emotional or mental need that they are trying to meet? Your client is down or sad, but they're unable to put into words what it is they're feeling. And then it can be helpful to find an alternative behavior that will meet the same need. Instead of becoming physically aggressive, encourage your person to go for a walk, run, or do something physical that can help release that pent-up aggression. Oftentimes, having this alternative behavior is easier than trying to just stop a behavior. And offer distractions that suit the person's interests or preferences. Listening to music, going for a walk, talking with a family member or friends. And then we want to continue teaching and reinforcing positive, healthy coping skills. Things like journaling, deep breathing, any kind of guided meditation, whatever might be effective for them. A big note here is that when someone is in that crisis, that is not the time to attempt teaching coping skills. That person is experiencing dysregulation with impaired cognitive functioning. I like to use the analogy of stop, drop, and roll. We don't teach someone to stop, drop, and roll when they're on fire. We teach them these things outside of emergency situations so that way they're better prepared. And we just need to make sure to be conscious of our own triggers, what sets us off personally. If there's a specific individual or a specific behavior that when you see or experience, it's causing a response in you. Recognize our own triggers as an importance in allowing us to work through our own potential issues so as not to put them off onto our clients. And what about during an actual crisis? How do you respond to others around you and the crisis itself? Your tone of voice should be calm, unexcited, but it's vital that your nonverbal responses match those verbal responses. Body language speaks volume. Keep a relaxed state, being mindful of where or how we're holding our hands, open hands versus closed fists, hands on hips versus arms to the side, held at the waist in a non-threatening manner. Knowing when to tag team or when to step back and let a peer take over is a valuable skill. Recognizing our own limits is not a weakness. It can be a great strength, especially when you remember your own triggers. If you don't think you will be able to de-escalate someone in that moment, tag team and find someone who can. And we're going to get into those positive actions to actually utilize with your individuals. Make sure to anticipate possible problems and avoid them. Know and avoid the triggers for possible challenges or any kind of difficulties. And if that is not possible with your client's participation, plan ahead for challenges and have solutions worked out. If someone doesn't like bright lights, don't turn on the overhead lights. And know the signs. What does it look like when the person is feeling stressed, anxious, angry, or fearful? Things like fidgeting, withdrawing, becoming agitated. As soon as those signs are evident, address them immediately in positive ways. Praise and reward the person. Remember that positive reinforcement. Individuals will respond more positively when they are being recognized for displaying effective and appropriate behavior. Listen, truly focus on the person. Watch, listen, try to see the world through their eyes and let them know you are there to support them. Know their routine. Know, respect, and implement their routine. If there is no routine, assist the person in establishing one. Let the routine be the framework for structure and activity. Make sure to give them choice. Assure the person has as much choice and control as possible. Even if an activity may be necessary, A person can have choices around when it happens, where it happens, with what it happens, how it happens. Let residents choose quieter times for activities and give warnings before touching or moving. Avoid saying no to the person and be tolerant to the person saying no to you. No is often a trigger for problems because it leaves no room for choice, negotiation, or alternatives. Clients have a legitimate right to say no, and in some cases, it's the only way that individuals can protect themselves and assert their rights. If something cannot be accommodated, offer alternatives rather than saying no. And model the best. We teach clients appropriate and effective skills and behavior. Respond to challenges in the same way and circumstances in the best way possible. So do not set a standard for the person that you yourself do not follow. Demonstrate calm, control, problem solving, respect, and consideration for everyone, coworkers as well as clients. Show the person what to do through your own behavior, not just your words. And what can we as providers and caregivers do to help reduce behavioral escalation? There will be, and probably already have been, times when our responses to situations made the difference between a good or bad outcome. Let's talk about some basic, simple steps we can take to aid in reducing behavioral escalation. First, I've already been saying it, remain calm, no matter what. Remaining calm is number one for a reason. As long as you are calm, you have a much better chance of calming your individual, as well as being able to maintain focus on the situation at hand. Not to mention reminding us that the people we care for do look to us for cues in situation. If a person experiencing mental health symptoms, some of these behaviors can be completely out of their control. Be patient with them and be understanding. Be forgiving. It's vital for those we care for to know that we forgive them when things do escalate. They need to know that you will come back and that things will be okay. Modeling the act of forgiveness for clients is also a great tool to teach them that it's okay to forgive and move forward. Be caring, gentle, and non-judgmental. Make sure to listen without judgment. Show that you do care. Be that shoulder they may need, or just that sounding board to work through something. Be that safe person for them. Hear them out without expressing opinions or relaying anything negative with facial or body expression. Be that safe space, especially because everyone's reality is different, and there is no way of knowing exactly how someone feels. Be honest. I cannot stress the importance of being honest. Clients must know that no matter what, they will get 100% honesty from you as their caregiver or provider. They must be able to trust whatever you tell them, which goes right along with not making promises, especially promises you cannot keep, not even when they are of the best of intentions. We all know when someone is being fake or insincere with us, just going along with us and telling us what we want to hear. The people we serve are no different, so don't think you're fooling your client. Sincerity truly does matter. And be respectful. Be respectful of them and their beliefs. It is not our role to judge or try to change what they may believe in. Our role is to support that person to the best of their abilities, not to have an opinion about their belief system. What would make them feel safe? Don't force a conversation and let your individuals come to you. Then you can literally just ask them. Ask how you can help them feel safe or better. Maybe they want to go to their room or at least a quieter area. We should follow through by offering to go with them to a quieter area or take a walk to get away from the present environment or whatever it is that has them agitated. Express empathy, encouragement, and support. Use active and reflective listening, then acknowledge what they are telling you by repeating it back to them with your understanding of what the issue is. What I am hearing you say is that you're frustrated, sad, mad, happy. If you got it wrong, again, it's okay. It's okay to be wrong. Your clients will tell you. We want to make sure to get it right in order to offer the support that they need in that moment. Be empathetic to them and offer that much needed encouragement along with your support. Allow time to process. If someone is at the beginning stages of a crisis or is already upset about something, it may take them a minute to recognize what it is you are asking of them or to give a response. It doesn't mean they are trying to be difficult or ignore you. It just means that there is a bit of a processing delay. Just be patient or repeat your request if needed. They'll get there. 9, validate their experience. Never be dismissive or belittling, regardless of what your opinion about what they are upset over. Regardless of what you think, it's clearly something important to them. We must always be genuine and sincere during these interactions. Validate them and how they're feeling in that moment. Telling someone who's experiencing mental health symptoms to be strong, don't cry, calm down, or relax, or using sarcasm can come across as condescending. It's dismissing what they are dealing with and minimizes their feelings. It can actually create more anxiety for a person who is already distressed. 10, meet them at their level, both literally and figuratively. Literally, if your client is seated or laying down, take a seat to be at or as close to eye level as you can be. It's not okay to stand or tower over someone, as that can be perceived as intimidation. We also don't want your client towering over you. And then figuratively, don't be overly clinical when talking with clients or patients. While it may be perfectly understandable, stop and think if your patient actually knows all those clinical terms you just tossed out. Make sure that they can understand you and your language. Anytime we are working with a client who has become escalated, the only focus is how the situation can be safely de-escalated. That's really it. Honestly, that's all. We want to keep everyone safe. It's not proving that we are right or that we know better than our client. When we get into these ego battles, oftentimes things are only going to escalate further. And none of us share the same reality. So someone's perception of a scenario is going to be different from someone else's perception of the same scenario. All right, so that's all that I have for you today. If you have any questions or concerns, please watch this video again or reach out to your direct supervisor for further information. Otherwise, have a great day.